Hello, everyone. My name is Matt Dukewich. I'm a GI and liver disease fellow. I'll be presenting patterns and effects of re-abstinence after harmful alcohol use following early liver transplant for severe alcohol-associated hepatitis. This is work from the Accelerate AH Consortium. My author is listed here. Accelerate is a multi-centered consortium from 12 liver transplant centers across the United States collecting retrospective data on early liver transplant for severe alcohol-associated hepatitis. So there's a little bit of background we'll have to go through to really understand this project. We'll talk about what alcohol-associated hepatitis is. We'll talk about whether there's treatment for this. We'll define early liver transplant and talk about the burden of alcohol use after early liver transplant. So alcohol-associated liver disease, or ALD, develops in up to 35% of those with alcohol use disorder. ALD is a spectrum of disease from simple benign hepatic steatosis or liver fat deposition all the way to decompensated cirrhosis. Globally, ALD is the #1 cause of cirrhosis, and ALD is responsible for 50% of liver-related deaths in the United States. Alcohol-associated hepatitis, or AH, is a severe type of ALD that develops in patients who have underlying liver disease and ongoing active drinking. What is unique about AH is that this is often the first diagnosis of ALD for many of these patients. In its severest forms, severe AH is associated with infection, multi-organ failure, and decompensated liver disease, with a very high short-term mortality, up to 50% at 3 months and up to 70% mortality at 6 months in its most severe forms. Long-term survival beyond 3 months is truly dependent on alcohol abstinence, and there's no pharmacotherapy approved by the FDA for AH, but corticosteroids have been shown to improve short-term 30-day survival in a small subset of patients. Because AH is associated with recent alcohol use, these patients historically have not been eligible for liver transplant due to this 6-month rule, which required 6 months of abstinence prior to liver transplant for ALD. Because of such high mortality, there's been much interest in studying whether these patients can safely undergo liver transplant. And one of the first studies assessing this formally was a prospective study in 2011 that looked at 26 patients in France and Belgium who underwent liver transplant for severe AH without a mandated period of sobriety. And this demonstrated excellent 6-month survival of 77% in the liver transplant group versus about 20% in the non-transplanted group. Further work has been done, including the first retrospective study from the Accelerate AH group in 2018, which looked at 147 recipients of early liver transplant and found 84% 3-year survival, which is comparable to a historical cohort of patients who underwent liver transplant for ALD with 6 months of sobriety, who had a similar 3-year survival of 83%. Because of this, early liver transplant is well adopted and is now the fastest growing indication for liver transplant. There's several patterns of alcohol use after liver transplant, and this is of significant interest to the field. As you can see here, this is retrospective data from the Accelerate group. We have broken down basically 4 patterns of use. We find that about 70% of patients remain abstinent after liver transplant, but there's varying percentages of use and patterns in the remaining 30%, with about 8% having this particularly worrisome early heavy use, with early use being within 1 year after liver transplant. The blue and the red lines here really show that burden of early heavy alcohol use, with poor survival starting even at 1 year after liver transplant and persisting even out to 5 years after liver transplant, specifically in the blue, which is the early but non-heavy use, and the red, which is the early and heavy use groups. So moving into the study, we wanted to show whether returning to abstinence, which we'll term re-abstinence, following an episode of post-liver transplant harmful alcohol use restores the survival benefits of those patients who remained abstinent or who had no harmful alcohol use. This is retrospective analysis of recipients from 2006 to 2021. We defined harmful alcohol use with either binge or frequent definitions, binge being consumption in less than 24 hours, or frequent being a weekly definition, or we use the serum biomarker of alcohol consumption, phosphatidylethanol, or PEth. We defined re-abstinence as at least 12 consecutive months with no harmful alcohol use following one episode, or at least an episode, of post-liver transplant harmful alcohol use. We looked at all-cause mortality after liver transplant, And patients were grouped into dynamic alcohol use categories throughout follow-up. They were either no or not yet harmful alcohol use. They could have been re-abstinent after harmful alcohol use, or in a group that was having continued harmful alcohol use. We did a survival analysis with a Cox proportional hazard model, adjusting for age, melted liver transplant, and sex, and used logistic regression to identify if there were factors associated with achieving re-abstinence in those who had harmful use. In this study, we looked at 347 patients, retrospectively from, 2006 to 2021, with a mean follow-up of 2.2 years after liver transplant. 80% of this group had no episodes of harmful alcohol use after liver transplant. Of that remaining 20%, there was half that had continued harmful use with no re-abstinence and half that had at least one period of re-abstinence. Comparing those two harmful use groups, those who had re-abstinence after liver transplant versus continued harmful alcohol use, they were similar in demographics and clinical characteristics and psychosocial characteristics, and had similar patterns of alcohol use, such as time to use and quantity of use. We have here a breakdown of the patients in each group at each interval of follow-up, with blue being no harmful use, green being the continued harmful use, and red being the re-abstinence group. This table here shows the similar baseline characteristics in demographics between the groups, similar in age, sex, race, ethnicity, BMI, and MELD liver transplant. Just to highlight that MELD is a score of liver disease severity and goes up to a effective threshold of 40, so this is a very sick population. These groups were similar in some psychosocial history as well, family history, history of psychiatric illness, history of substance use pre-liver transplant, as well as their drinks per day or years of heavy drinking before liver transplant. The groups did differ in characteristics of failed alcohol rehabilitation attempts or legal history related to alcohol use before liver transplant. You can see that these were higher in the harmful use groups. And what was important was that the continued harmful use group had predicted 5-year survival of about 77%, continued at 93% for that no harmful use group. And those who had re-abstinence, they had similar, almost identical survival at 5 years to those who had no harmful use. We descriptively looked at the alcohol use interventions that were reported when any alcohol use was detected, so this is not just harmful use. And we found that overall there was pretty poor uptake of alcohol use interventions, particularly pharmacotherapy. We conducted several sensitivity analyses to compare some of the definitions we used and basically found that there were no differences from our baseline model. In conclusion, we found that re-abstinence after post-liver transplant harmful alcohol use restores survival comparable to those who had no post-liver transplant harmful alcohol use. We found there's low utilization of interventions for alcohol use, and the benefits of re-abstinence appear to be greater than or equal to 12 months of re-abstinence. Moving forward, some future questions to address would be what the optimal methods for detecting this alcohol use, how should we treat this, how do we increase uptake of the interventions that are available, and kind of better characterizing these relapses or return to use after liver transplant. Just want to thank my mentors, Brian Lee, Nora Thoreau, the Gen Dodge for Statistics, and all the Accelerate AH Consortium group members. Thank you.